Good afternoon. My name is Dr. Renelle Miles, and I want to welcome you to the NIH Office of Disease Prevention Medicine Mind the Gap webinar series. This webinar series explores research design, measurement, intervention, data analysis, and other methods of interest to prevention science. Our goal is to engage the prevention research community in thought-provoking discussions to promote the use of the best available methods in prevention research and to support the development of better methods. Before we begin, I have some housekeeping items. To submit questions during the webinar, there are two options. First, you may submit questions via WebEx by clicking on the question mark in the WebEx toolbar and direct questions to all panelists. Second, you may participate by Twitter and submit questions using the hashtag NIHMTG. At the conclusion of today's talk, we will open the floor to questions that have been submitted via WebEx and Twitter. Lastly, we would appreciate your feedback about today's webinar. Upon closing the WebEx meeting, you will be directed to a website to complete a seminar evaluation, and also send an email with a link to the evaluation. Your insights will help us to continue to improve this webinar series. At this time, I'd like to turn things over to Dr. David M. Murray, Associate Director for Prevention and Director of the Office of Disease Prevention.
Thank you, Renelle. Dr. Maria Fernandez is a professor of health promotion and behavioral sciences at the University of Texas School of Public Health in Houston. She is also director of the Center for Health Promotion and Prevention Research. Her research is focused on cancer prevention and control among underserved populations. She has conducted studies on the identification and description of basic behavioral conceptual models of cancer screening and vaccination, the development and evaluation of new interventions to increase cancer control, and the science of understanding and intervening to accelerate the use of evidence-based interventions in real-world settings. Dr. Fernandez has extensive experience in research translation as well as in dissemination and implementation research. She is a member of the NIH Dissemination and Implementation Research in Health Study section. Her recent contributions to implementation science include studies to better understand factors influencing the implementation and sustainability of cancer control practice change in federally qualified health centers, and the development of a conceptual model to guide dissemination research and intervention planning. It's my pleasure to welcome Dr. Maria Fernandez and turn the session over to her.
Thank you. Let's see. Okay, thank you very much. Today I'm going to be talking about dissemination and implementation research and highlighting challenges and opportunities in this area. One of the quotes that I really like that I think embodies my interest in this area and in fact a lot of the attention is this one by Khalil Gibran: "A little knowledge that acts is worth infinitely more than much knowledge that's idle." And one of the reasons that I became interested in implementation and dissemination research is that through many years of developing cancer control and other types of interventions, I found that in some cases, even when they worked, it was unlikely that they were ever used broadly or scaled up to have the public health impact that we hope will happen when we develop such interventions. And in fact, NIH has made this statement that I think embodies the importance of this type of work, and that is closing the gap between research discovery and program delivery is both a complex challenge and an absolute necessity if we're to ensure that all populations benefit from the nation's investments in new scientific discoveries. And in fact, the field of implementation research seeks to close this gap. It supports the movement of evidence-based interventions and approaches from experimental controlled environment into the actual delivery context where the program's tools and guidelines will be utilized, promoted, and integrated. So what about a definition? The NIH provides these definitions, and there are several in the literature, but these are good ones to use as guidelines. Dissemination is the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. And so it answers questions about or it seeks to answer questions about how, when, by whom, and under what circumstances evidence spreads through the agencies, organizations, frontline workers, and consumers of public health and clinical services. Whereas implementation focuses on the use of strategies to adopt and integrate evidence-based health interventions and change practice patterns within specific settings. So here it seeks to understand the behavior of healthcare providers and support staff, healthcare organizations or others that are implementing an evidence-based approach, even policymakers in the context of key influences on adoption, implementation, and sustainability of evidence-based interventions and guidelines. So when we think about research to action and we recognize that there's a gap, we ask questions about who's responsible? Who's responsible for getting research used to influence public health? Is it researchers? Are they program developers, implementers, health service providers, funders, politicians? One of the barriers to translation is that people believe that the responsibility for dissemination lies elsewhere. I had the experience of going to a very early conference in this area of implementation science in 2002. It's actually held in Corpus Christi, Texas, in which we asked folks, we divided people up into researchers and practitioners and funders, and asked them who's responsible for evidence and evidence-based approaches and innovations to be used in practice in public health. And the response was not surprising. You know, researchers said, I don't have the training or interest in approaches to enhance dissemination of research products. Grant funding doesn't support such activities. And in fact, promotion and tenure guidelines don't necessarily support those types of activities. And then practitioners thought, well, yes, it would be great to be able to use the products of research, but how do we do that? It's way too hard to do right now, and they believe that the responsibility for summarizing and making research products useful and practical laid elsewhere. But if they also said that if they were easy to find and use, that we would do it. So implementation science is a relatively new field, right? It's probably not in its infancy, but maybe its tween years. And there are many different products now that help provide information and guidelines on implementation science. And they include this excellent resource, a book by Ross Brownson and colleagues, on dissemination and implementation research in health, which really includes many of the fundamentals, a journal, Implementation Science, which is an excellent journal providing the latest in implementation science research, and then some excellent conferences, including a conference that I'll highlight at the end of the talk that happens in December of this year. So what are we referring to when we talk about implementation science? Where does the field of implementation science lie? And here I'm going to be using a framework or a diagram described by Enola Proctor that I think does a good job of answering this question. The typical sort of research is trying to look at health outcomes as a result of something that's developed. It could be an innovation. Here I'm calling it an evidence-based intervention. And so this is really the usual. How does this impact health outcomes? And when we talk about implementation science, though, we're talking about questions about, well, how does this get implemented and used in practice? And what are some of those intermediate outcomes that have a great impact ultimately on outcomes, such as the feasibility, the fidelity, the penetration, the sustainability, the costs? And what are some of the service outcomes, such as safety, effectiveness, equity, right? So the field of implementation science sort of lies here, and it's actually broadening. And I'll tell you in some ways in which it's stretching across the whole sort of the whole gamut of research that includes the what and the impact. I'll talk about that in just a little bit. So oftentimes we're asked, what are the types of D&I questions, dissemination, implementation, research questions that are appropriate? And these can include questions about factors influencing adoption, implementation, and sustainability of evidence-based programs, policies, practices, or other innovations. It includes testing models and frameworks. I'm going to talk a little bit about some of the common models and frameworks in implementation science, but there's much work to be done in that area. The relationships between various constructs that we know influence implementation, predictors of implementation outcomes, and measurement studies. And then there's also questions related to the development and evaluation of strategies, implementation strategies or interventions that are developed to increase adoption, implementation, and sustainability. There's questions related to scale-up. So once we do find that something has worked in a particular setting, what's the best way to get it scaled up, to get it used in multiple settings and multiple populations? Related to that, there's questions about adaptation. How do you adapt interventions in order to increase scale-up and increase fit across different settings and populations? And then there are questions related to sustainability. Once you implement something, how do you maintain either its effects or how do you maintain the program itself? So this is a slide that I borrowed from excellent implementation researcher Brian Mittman, in which we see the difference between clinical research and implementation research on a number of different study features. Typically, in clinical research, and the same, we could put public health in here as well, the type of, the aim is to evaluate a clinical intervention or a public health intervention to change maybe behavior. And in implementation research, we're usually evaluating an implementation strategy or an implementation approach to get something that's been developed used in practice or in a public health setting. A typical intervention in clinical research can be a drug, a procedure, a therapy, a health behavior intervention. In implementation research, a typical intervention tries to change organizational practice. It could include a training. It could include various approaches such as audit and feedback to change practice and the way things are done. Typical outcomes in clinical research include symptoms, health outcomes, patient behavior, whereas in implementation research, it's adoption, adherence, level of implementation. And then the typical unit of analysis is usually different as well, whereas in clinical and public health research, it's often the patient or the community member. In implementation research, it's usually a clinic, a team, a facility, or a school. Those making the decision to adopt, those actually doing the delivery of the innovation. So how do we increase implementation? Well, unfortunately, this is often a haphazard process, and I've heard this principle, the is-lagiat principle, from Jeremy Grimshaw in a presentation. And what do we mean by that? It seemed like a good idea at the time, right? So we don't want to do this. We don't want to decide on implementation strategies just because they seemed like a good idea at the time. We want to take as much care in planning and choosing implementation strategies as we do when we're developing innovations, clinical treatments, and behavioral public health interventions. So what are implementation strategies? Well, implementation strategies have been defined as methods or techniques used to enhance implementation, right? So anything from adoption, implementation, sustainability, or all of those, of a clinical or public health program or practice. It's the how-to component of changing healthcare or public health practice. And I like this quote by Carolyn Clancy: it's how to make the right thing to do the easy thing to do. So we often wonder, why aren't our interventions adopted? Why aren't our public health or practice change interventions readily, used? They work. There's evidence that they work. Why don't people use them? Well, many times it's because it's hard to do that. It's hard to change practice. It's hard to change the way things are done. And there may be lots of different factors, contextual and otherwise, that make them not that easy to do. So part of what we want to focus on in implementation strategies is making the right thing to do easy. So there are different types of implementation strategies, and this is a categorization by Byron Powell and Enola Proctor have described, and that includes discrete, multifaceted, and blended. And the difference between these, it's really, they're sort of categories. Discrete just means it's a single action or process, like, for example, using a system of reminders. Multifaceted, so a combination of multiple discrete strategies. Or blended. So blended is usually multifaceted strategies that have been protocolized, in a particular way, and they're often branded. There's been a lot of interesting and recent work done in trying to look at the literature and understand the various strategies that are listed there. And Byron Powell had, in 2012, published this work, a compilation of strategies for implementing clinical innovations in health and mental health. And in this, looking at the literature and the various strategies, the processes they used ultimately resulted in a compilation of 68 discrete implementation strategies that focused on enhancing implementation by planning, educating, financing, restructuring, managing quality, and attending to the policy context. And then the compilation has since been refined through the Expert Recommendations for Implementing Change, or ERIC study, which sought to develop a wider consensus of strategy terms and definitions. And they engaged 71 experts in implementation and clinical practice in a modified Delphi process. And this resulted in a refined compilation of 73 discrete implementation strategies. And these are the ones that came out of that process. So these are, again, they're sort of categories of implementation strategies. And I think that this has done an excellent job in moving the field forward in this regard. I also think that there's a lot that needs to be done. There's a lot that needs to be done in trying to understand what are the change mechanisms that exist in these strategies. Why do we think these strategies are going to work? And that's some of the work that needs to be done in the planning of implementation strategies and in the decision making for which type of strategy you're going to use. So the evidence base for implementation strategies is mixed. There are several strategies that are found to be effective under some but not all circumstances. Most strategies result in modest improvements. Passive approaches generally don't work so well. And there is actually mixed evidence regarding the effectiveness of multifaceted implementation strategies. So again, a lot of work to be done in this area. But where can you find them? There are several areas that you could find implementation strategies. They include reviews and compilations, textbooks, treatment and strategy manuals, literature searches, learning from positive deviant situations, and of course, developing your own. And in just a little bit, I'm going to talk a little bit more about the process of developing your own implementation strategies and some key concepts behind that. So looking at this continuum of the stages of research and understanding where D&I studies typically fit in, we're usually looking at this process that can start with very early pre-intervention studies, then efficacy studies, then effectiveness studies, and then finally all of these different types of studies that look at the process of implementation. Now, this is sort of the way things usually work, but there's a lot of negatives to this and the shortcomings to this type of sequential model. And some of them have been highlighted by Jeffrey Curran and his colleagues, and they include the fact that traditional clinical effectiveness research tends to declare victory early and is considered finished when effects are shown in one or more settings, right? But they may be results from efficacy studies and may not really have a lot of application or external validity. So there's some limitations there. And then on the other end, traditional implementation research tends to buy into the fantasy that the innovation is ready for dissemination just because it has some established efficacy. But what do we do? The problem is that this could result in endless RCTs of innumerable tweaks of various specific applications in different settings, each followed by an implementation study. It's a long loops, long time to public health impact. So obviously we don't want this, right? So Jeffrey Curran and others have suggested some alternatives. And so there's this excellent paper, Effectiveness Implementation Hybrid Designs, in which he talks about a number of different approaches for really kind of combining effectiveness and implementation research. So why are these types of designs desirable? One is that the speed that we already said is pretty slow of moving research findings into routine adoption could be improved if you consider these designs that combine elements of effectiveness and implementation research. So in these cases, we aren't waiting for the perfect effectiveness data before moving forward to implementation, and at the same time, we're still looking at effectiveness data, so essentially backfilling effectiveness information while we're testing implementation strategies. So not waiting to test implementation strategies until we have all of the information of effectiveness. So spatially speaking, in this diagram from Brian Mittman, where we're looking at efficacy studies and effectiveness and implementation and scale up and spread, this is where it fits. This is where hybrid designs fit. And they describe 3 different types of designs: hybrid type 1, type 2, and type 3. And they really fall on this continuum from effectiveness through research to implementation research, where a hybrid type 1 is putting its emphasis on testing the clinical or prevention intervention and observing information on implementation as a secondary sort of emphasis. So you're testing the effectiveness of this approach, and you're also gathering information on implementation. For type 2, it's more of an equal attention to testing a clinical prevention intervention, but also testing an implementation strategy. And then type 3, it's really the flip of type 1, where the primary objective is to test implementation strategies, but you're still gathering information about clinical or prevention outcomes. Now, this is a nice approach when you're testing implementation strategies as a primary concern, but all of the information about the effectiveness of that particular innovation is not yet available, or perhaps not available in the types of settings and populations that you're working in. I'm going to switch now to some discussion about theories and frameworks in D&I science, and I'm going to highlight several. First of all, what do we mean when we talk about theories and frameworks, and what are the differences between these? Theories describe a way of understanding events and behavior. They provide descriptions of interrelated concepts or constructs that explain or predict events or behaviors by spelling out the relationship between the variables. So theories, by definition, are not content-specific. They're generic, they're abstract, and they're broadly applicable. That's what makes them theories. Frameworks are conceptual structures or scaffolds that can provide a systematic way to help develop, manage, and evaluate interventions. So they're more context-specific. And while they're conceptually different and often, frankly, used interchangeably in the literature and otherwise, both theories and frameworks can be used to enhance D&I research. So I want to just give a caveat for the use of models or frameworks. So I often use the term models to refer to both theories and frameworks. So there's no comprehensive model that is appropriate for every study or every program. While there's some really nice models that help, and you'll see some of them, that help us understand the context and the influences on implementation, partly because the field is relatively new. Not all of these models are well operationalized yet, right? We're not sure how to measure these constructs within these frameworks. And that models should be considered dynamic, particularly in a relatively new field. As we learn more about the relationships of these constructs, we may actually realize that there needs to be some tweaking or different categorizations of these frameworks. So in 2012, Tavik and colleagues did a review of various frameworks and models, and they used snowball sampling to identify them, and ultimately, identified 109, and then after excluding some for various reasons, had 61 models. And they came up with several categories, including which models had construct flexibility, were in line with the socio-ecological framework, were dissemination models versus implementation models. So that's a very interesting, important paper in trying to understand, some of what's out there. And there was also a review by Nielsen in 2015, and here he conducted a narrative review of selected literature to identify the theories, models, and frameworks used in implementation science, and categorize them into these three sort of big buckets, and said, where there's models that are process models, and process models describe or guide the process of translating research to practice. There's evaluation frameworks, so models that help us think about evaluation within an implementation context, perhaps looking at implementation outcomes and things like reach and impact, in addition to impact. And then there's frameworks for understanding or explaining what influences implementation outcomes. And under those, he categorized three different sort of sub-categories of these understanding and explaining frameworks. And those were determinants frameworks, classic theories, and implementation theories. So I'm going to give you an example of some implementation frameworks, and I'm going to start with one of the oldest ones, and that's diffusion of innovation theory. I had the pleasure of meeting Everett Rogers. Actually, it was at that 2002 conference that I mentioned, and as a student in health promotion who had studied diffusion of innovation theory, it was like quite an honor to meet with him and talk with him about some of these issues. But Rogers was one of the first to start talking about the process of how innovations are adopted and implemented. And his work started in agriculture, in trying to understand why certain farms use technologies and innovations and others didn't. So it describes how new ideas, products, and behaviors become norms. It addresses all levels, individual, interpersonal, community, and organizational. And the success of implementation and diffusion is determined by things like the nature of the innovation. and the characteristics of that innovation. There are certain innovations that are more likely to be adopted and implemented than others. The communication channels that are used, the time that's available for adoption, and then also the social system and how different organizations or systems interact with each other and influence each other in terms of implementation. So diffusion of innovation theory is still often used in grant applications and papers and trying to understand implementation. But what's important to note as well is that in other frameworks and models that have been proposed, including the ones that a couple of the ones I'm going to describe here, many of the concepts of diffusion of innovation theory are incorporated into those. And another framework that is a very popular framework that is used to understand implementation, this adoption, implementation, and sustainability is the REAIM framework. Many people think of it as an evaluation framework that signals the kinds of outcomes that we need to track, right? REAIM draws upon work in several areas, including diffusion of innovation, multi-level models, pre-seed, proceed, and it helps us understand who it is that we're trying to reach, the assessment of effectiveness, how do you develop support for adoption, how do you ensure that interventions are delivered properly, and how do you incorporate interventions so it's delivered over the long term. There's actually an excellent website, and if you just, I should have listed it here, but if you just type in REAIM, it'll come up, that has a lot of resources on REAIM. So REAIM is an acronym, you've probably figured it out from the last slide, that includes reach of the target population, efficacy or effectiveness, adoption, implementation, and maintenance. The next framework that I'm going to highlight today is the Consolidated Framework for Implementation Research, and this was developed by Laura Damschroeder, and it builds on work that had been done by Trish Greenhall and others. But this framework describes a number of different domains and constructs within those domains that describe how an intervention sort of moves through an organization and is influenced by the inner setting of that organization, the individuals involved, the process that's used as it's implemented, and then also the outer setting that's influencing and influencing this process. So the Consolidated Framework for Implementation Research, or CFIR, as it's referred to often, is an overarching typology, right? And it's used to promote implementation theory development. So it's not a theory in and of itself, but it can help us understand and test different relationships within these constructs to build theory. As I mentioned, it builds on Greenhall's synthesis of 500 sources plus newer articles, and it's considered meta-theoretical. So this is, I think, one of the reasons I really like this framework, and it's a reason that this framework has been utilized a lot in implementation science. And it's because it is meta-theoretical, that it's a synthesis of existing theories. However, there's really no depiction of the interrelationships, ecologic levels, or specified hypotheses of how these work together. It's composed of 5 major domains. I already mentioned these. And within each of those domains, there are different constructs. So in characteristics of the intervention, they include things like, is there a relative advantage? How adaptable is it? How complex is it? So things that actually come from diffusion of innovation theory. It includes constructs in the inner settings, such as the structural characteristics of that organization, the networks and communication, the culture, the climate, and readiness for implementation. It includes this outer setting domain that has constructs like patient needs and resources, cosmopolitanism, peer pressure, external policies and incentives, right? So these are all things that can influence whether something is implemented. And then characteristics of the individuals. So how much knowledge there is about the intervention, how much self-efficacy, confidence in their ability to implement it, and various other attitudes. And then there's the process of implementation. So what kind of planning, engaging, executing, reflecting, and evaluating goes on. Okay, so those are all, and I know that this is a really quick overview, but the intention is to just give a little bit of exposure of some of these main implementation frameworks and models, and then for you to look into it a bit more if you're interested. So there's a lot of opportunities for research, and one of the areas is in measurement, and this is an area that I have been interested in, and my colleagues from the Cancer Prevention Control Research Network have done a lot of work in this area in assessing CFIR constructs, right? So the work includes assessing constructs for salience, being able to operationalize them, understand what levels the constructs should be evaluated in, and then the timing for that measurement. Okay, I'm going to switch to another framework. This is the Interactive Systems Framework, developed by Abraham Wandersman and colleagues. And in this framework, there are a number of different systems that are involved in the implementation. And these include a synthesis and translation system, a support system, and a delivery system. The Interactive Systems Framework essentially provides a heuristic for understanding the different systems, functions, and relationships that are involved in the dissemination and implementation process. It helps us identify stakeholders and how stakeholders can interact. It's a useful way of organizing implementation theories from different disciplines and helping us understand, oh, well, this one helps us understand the delivery context. It suggests important areas for new research and activities that could improve dissemination and implementation. So more recently, Jonathan Scatia and Abe Wandersman and others have come up with this additional heuristic, right, that builds off of the Interactive Systems Framework, and it's called readiness, right? And conveniently, it translates into R equals MC squared, and that is motivation times capacity squared. And when we're talking about capacity, we mean general capacity, so that's in that support system, as well as innovation-specific capacity. So these are the types of capacities that are important in implementation. And so readiness within this context, within this sort of definition, goes beyond just understanding whether a particular organization is ready at the beginning of an implementation effort. It could be used for that. But it also is intended to be used for understanding as something is implemented, how do these things change? How does capacity change? How does innovation-specific capacity change? How does motivation? How do all these things influence the actual implementation? And probably more importantly, how can we intervene upon things like motivation and the different types of capacity to increase implementation effectiveness? So there are a number of different types of capacity that, and you'll see some commonalities with CFIR here on some of these constructs. I'm working together with Jonathan Scatia and Abe Wandersman and others on the development of measures for these several different constructs within general capacity, innovation-specific capacity, and also motivation for innovation. And as you can see, many of these come from diffusion of innovation and the other models that we've seen. So I wanted to talk, I had alluded to some of the challenges in understanding what kinds of strategies to use for implementation and also even in selecting them. And so I'd like to just take a moment to talk a little bit about developing strategies to increase adoption, implementation, and maintenance. And there are a lot of different processes for doing those. My main message is that it should be a systematic process. It should be a systematic process that includes participatory approaches and really understanding what the adoption, implementation, and sustainability goals are and activities need to be. So one approach for doing this type of implementation planning is using intervention mapping. And intervention mapping is basically a systematic approach for program development, implementation, and adaptation. And because it includes development, it actually goes beyond just development of dissemination interventions. It could also be development of an intervention from the beginning. And so because of that, there are actually 3 ways that intervention mapping can be useful for dissemination and implementation. And the first is in designing programs in ways that enhance its potential to be adopted, right? So including things like including implementers in your actual planning. But what I want to focus on is, another way is to use these processes for adapting interventions. But what I want to focus on is the design of dissemination and implementation interventions to increase implementation. So this process guides the planner, right, or the researcher to answer the following questions. Who's going to decide to adopt and use the program? Which stakeholders will decision makers need to consult? Who will make the resources available? Who will implement the program? And will the program require different people to implement different components? Who will ensure that the program, and I'm using program, but it could be any innovation, who will ensure that it continues as long as needed? What do they need to do? Why would they do it? And what methods and strategies influence these determinants of adoption, implementation, and maintenance? So it's a very specific systematic process that takes the planner through answering these questions using the intervention mapping approach to come up with an intervention. So here's this is a figure from the book where here you have the evidence-based program, and here's the implementation intervention. So the focus of this planning effort and the planning approach that I'm talking about right now is to develop this implementation intervention. But in order to do that, you have to sort of start from the right here and ask questions and analyze it going backwards. So obviously the outcomes are to adopt and implement and maintain this particular innovation. In this case, I'm calling it a program. And then who has to do what in order to adopt it, to implement it, to maintain it, and then why would they do it? And then the selection of implementation interventions includes the decision about what methods, what theoretical change methods, and how those are going to be operationalized, which ones to use and how to deliver them so that they influence the determinants of implementation and ultimately implementation practice. I'm going to, just the last couple slides, I'm going to talk a little bit about there are several different funding opportunities, but I wanted to highlight one from the National Institute of Health. In the introduction, you were told that I'm a member of the Standing Study Section for Dissemination and Implementation Research. This is the numbers for the program announcement. So there are essentially 16 institutes and centers that including those listed here, that support this PAR. It serves to organize the dissemination and implementation research agenda across NIH. This number is probably higher than this now, but there are about over 150 grants funded through NIH since 2006, and there's been a standing review committee since 2010. And this is important because for people interested in dissemination implementation research, there needs to be some expertise in reviewing these types of grants. Otherwise, when they go to typical study sections, they might not really understand the focus. Some of the D&I areas that are ripe for exploration include things like sustainability of evidence-based programs in a changing context, adaptability or evolution of evidence-based programs over time, and how we can develop implementation strategies to address that adaptation and evolution, the impact of dissemination strategies on practice change, scaling up, this idea of de-implementation or ex-novation when we no longer want an innovation and we need to scale it back, the use of adaptive design, so testing implementation strategies as a stepwise approach, real-time feedback or monitoring, and then the use of big data for implementation research. So there are growing resources for implementation, including the ones that are listed here. There's a lot of excellent training programs. There's research infrastructure. There's measurement tools that are available in GEM and through some of these organizations and websites. There's now, many trainees that have gone through these programs that are becoming experts in implementation science, the journal that I mentioned, the textbook that I mentioned, and a really excellent conference if you're interested in this area of research is the annual Dissemination and Implementation meeting. This year it's in December 4th through 6th. And then this is just a list of some D&I resources that I think are really helpful that I'll leave you with. And that concludes my presentation. I'd be happy to take some questions.
Thank you, Dr. Fernandez. We do have some questions. So since you're a member of the standing study section that reviews this kind of research, members of our audience would be interested in what advice you would give, especially to investigators that might be putting in one of their early proposals. What kinds of things do the reviewers like, and what kinds of things do the reviewers not like in applications that come to that study section?
Yeah. Well, that's a very broad question, and there are lots of answers to it, but let me just highlight a few key things. When I reviewed the different types of hybrid designs, and I think that it's important that if you are submitting an application that is not necessarily a traditional dissemination or implementation study in the sense that it's testing an implementation intervention, so more like a type 3 or even just looking at the implementation intervention without effectiveness, it's important that you highlight that. So if you're submitting a study that is really most focused on effectiveness, but you're also doing some implementation assessments, it would be good to highlight that it's a hybrid type 1 and describe why you're doing that. It may be because while there's some evidence of effectiveness for a particular innovation, it hasn't been tested in a particular setting, and that's why the focus is on effectiveness. Another suggestion is that choose a model or a framework to use and make sure that you carry that through all the way through the application. So sometimes we'll see an application where they might mention REAIM or CFIR in the background section or somewhere early in the grant application, but it's not really reflected how they're going to apply that model or framework throughout the application. So it's important that it's used in depending on the type of application to inform the development of the implementation strategy or certainly the measurement of the outcomes. Let's see what else. And then earlier in the slides, and I don't know if I can see how I'll put it on types of research questions, right? So if I think that these couple slides give some good guidance about, is this, because I get asked a lot, is this a D&I research question? And so if it falls in this category of trying to understand factors that are influencing the process in some way, whether you're testing the model or doing some predictors or measurement of these constructs, then it probably does. And then if it's evaluating a particular strategy to increase the implementation, then I think that it probably does.
Many of the interventions that are used in D&I research involve multiple levels, and that suggests that multi-level methods for measurement and for analysis of the studies are important. Can you comment on that?
Yes, yes, that's absolutely true, and so I think, and as you probably know, while required, if you're doing a study that is functioning at multiple levels, it's also very challenging. It's challenging to oftentimes to get the number of organizations necessary to do some types of statistical analyses that are considering multiple levels. And so what I would suggest in this regard is be clear on what, for sample size calculations and things like that, be clear on what the primary outcomes are. For sure, measure across multiple levels, but you may not be able to power a study on every level. Another important consideration is as we think about the measurement of some of these constructs that I talked about, we really need to pay close attention about at what level they're being measured. So oftentimes we ask questions of individuals that are nested within an organization, and sometimes we're interested in the characteristics of those individuals themselves, and sometimes we're interested in their perception or their rating of the organization, such as when we're thinking about organizational culture or things like that. So those are things that you have to think carefully about, but absolutely, thinking about implementation, interventions, and strategies as a multi-level process is very important. I also would recommend the use of mixed methods approaches in the design and certainly analysis of these types of data. It's a way to overcome some of the limitations of that I mentioned, like sample size and things like that.
Hi, Maria. Can you hear us?
I can.
Okay, good.
We had a little technical difficulty on our end and lost the sound for a few minutes. Could you talk a little bit more about how adaptive designs can be used in D&I research?
Yeah, sure. So, and I am by no means an expert in this area, but I have collaborated on some projects that use adaptive design. So the idea of adaptive designs or interventions that are different in different contexts is that not everyone needs the same thing at the same time. And so, and it's the same with implementation, right? So for implementation, there are some organizations or groups that are making decisions about adoption or have different levels of readiness for implementation that need certain doses or certain types of strategies to increase their decision to adopt or their capacity for implementing. And some are different than others. And therefore, this idea of a one-size-fits-all approach, is probably not true. And so designs in which you're able to give different sort of doses and vary it by time to organizations in terms of implementation strategies is a really appealing one and interesting one. And this is particularly true because of the cost of some of these implementation interventions. So if you think about, a training to change a clinical practice, that might not be the first approach that you would try. In a scale-up effort, you might try a lower cost approach first, and then depending on the uptake or depending on the need, then you would follow up with a with a more intensive approach. So I think that those kinds of designs allow for that and allow us to test whether or not that makes sense.
Sure. Okay. So someone asked, was there another journal that you recommend besides the Implementation Science Journal?
Oh, yeah, that's a good question, and I wish I had thought of that before. I would have a list for you. I don't know if there's any ability to follow up, but I can tell you, you know, from my field, right? So for health promotion, behavioral science, public health, there are journals that are publish prevention research and I think public health research, intervention in particular, are interested in this. So one that I'm really familiar with is Health Education and Behavior. That's a journal that often publishes studies that have to do with interventions and evaluations of interventions, also are interested in implementation of those.
You can send us a list of journals if you'd like to do that, and we can post it with the other materials on the website. So it is absolutely possible to follow up.
I'll do that. Thank you.
Another question is, can you comment if community participatory research and implementation research are the same?
No, they're not the same. However, there are a lot of principles and processes within community-based participatory research that I think are absolutely essential for the work in implementation science. And Nina Wallerstein and others have done some really excellent work in this regard. And so just briefly, community-based participatory research, right, the principles are that you, or the main premise is that you involve the community, you involve those people who are going to be the targets or the priority population of whatever intervention in the entire process. So in the process of developing that intervention, in the process of evaluating it, et cetera. And so that same type of idea, that same type of sort of thinking about the importance of involving people who are going to be responsible for making the decision about adopting a particular innovation, those who are going to be delivering it, and those who are going to be responsible for maintaining it over time. It's incredibly important to include those people in the planning of implementation strategies and implementation interventions, as well as in their evaluation. And so, while not the same, I think that there's a lot of overlap, and certainly the principles and processes and even probably some measures of community-based participatory research can be used for implementation science.
Thank you. That's about all the time that we have for today. We really appreciate your presentation. There were quite a few more questions that were posted to the WebEx, and please feel free to email Dr. Fernandez those questions. So we want to thank you for all the useful information that you provided, and thank you to everyone who participated in today's webinar. On the Medicine Mind the Gap website, which is prevention.nih.gov/mindthegap, you will find several resources for this talk, including the slides, references, and a link to complete an evaluation. Your feedback is very important to us as we plan future sessions. Thank you again for your time. Please join us on June 15th for a webinar with Dr. William Vollmer from the Kaiser Center for Health Research about the use of electronic medical records in prevention research.
Thank you.